Hey guys, it's Joseph here again with Prep for Step, and in this video we will be discussing one of the more common bullous disease, or one of the more common blister diseases, called Pemphigus vulgaris. Now, Pemphigus means blister. Vulgaris means common, so by definition it's called the common blister. Now, patients will typically present with these busted blisters all over their body and in their mouth. And the reason the mouth is important is because if we compare this to one that's very similar to it called bullous pemphigoid, in bullous pemphigoid the mouth is usually spared. So you can get busted blisters in the mouth in this case as well. Now, the reason they actually pop so easily is because they're very thin-walled. And it's a very thin layer around them. So most of the times when patients do present, all of the blisters are usually popped, and you're not going to really find any round blister, maybe one or two, but most of them are already popped. Now, regardless of how you lose your epidermis, again, there's a problem with the epidermis here, obviously. So regardless of the etiology or the way that you lose your epidermis, the result and the clinical problems that can arise from that are the same. When you lose your epidermis, one of the most important things that immediately or in acute situations can cause death is dehydration, just like in burns, right? So when you lose your skin, you're losing all of those epidermis that usually blocks water from leaving your body. The other thing is you're prone to infections as well. There are millions and trillions of bacteria around us, and as soon as you take the first layer of defense, which happens to be skin, out of the picture, you're going to be more prone to infections. Now, these guys have a positive Nikolsky sign, and Nikolsky means that if you squeeze, I'm going to put a video in the description for you guys, a link to a video that you can watch showing the Nikolsky sign, but the idea is that if you press this horizontally, one of these horizontally, and very minimal pressure is needed, and the epidermis will just slough off. It'll just come right off, okay? Now, if it is untreated, this is also, keep in mind that Nikolsky sign is negative in bullous pemphigoid, positive in Pemphigus vulgaris, which is another difference between the two. Okay, so the pathophysiology of these guys and the way they're actually, what causes this is it's an autoimmune disease, okay? And we're basically producing antibodies against ourselves. Now, the antibodies happen to be IgG, all right, and they can be just idiopathic, means they just show up for no reason, against desmogliin 3 and or desmogliin 1. Now, what are desmoglians? Desmoglians are these cadherins. They're a type of these cadherins that hold two epidermal cells together. And this is really important because there's a big difference between this and the bullous pemphigoid. In bullous pemphigoid, it's against the hemidesmosomes. In the case of Pemphigus vulgaris, it's a true desmosome, meaning the channel or the attachment between two adjacent cells, as you can see right here. These cells are sitting next to each other, and this is the desmosome that holds these guys together via cadherin. But the problem is the patient has antibodies being produced against this, causing these guys to separate from each other. So they will easily be able to separate. Now, this could also be drug-induced, all right? And one of the major ones that causes this are all the prils, or all the ACE inhibitors that we give for diabetic patients and hypertension, right? Penicillamine, remember penicillin was a chelator that we use, for instance, in Wilson's disease or in cystinuria. Phenobarbital is an anti-seizure medication, and penicillin is penicillin. So these are the things that you need to remember when it comes to the pathophysiology of Pemphigus vulgaris. Now, our differential diagnosis would be, pretty much all the other blister diseases. The most important one being bullous pemphigoid. Okay, that's the closest one to this guy. Pemphigus foliaceus, or erythema multiforme, or Stevens-Johnson syndrome, which was usually known as toxic epidermal necrolysis. But the most accurate test for those taking Step 2 CS, the most accurate test for this one is a biopsy, which is this guy, but we don't use the biopsy per se by itself. We run a immunofluorescent type of study on top of the biopsy, which is this guy. So this is the most accurate test. All right, and what you're going to see on the biopsy, on the immunofluorescent test, is that you're going to see a net-shaped pattern it's going to illuminate in a net-shaped pattern. And really, the reason behind this is that basically among all of these epidermal cells, the antibodies are glowing. So it's going to be very in a net shape. You know, a cell could be here, here, and all of these cells that have connections in between them, all of these guys would light up, which is why you see this whole net pattern, okay? It's called the reticular or the net pattern. Now, the treatment, in the case of acute, the goal of our treatment is to lower those IgG antibodies that are attacking these epidermal cells, right? We're not talking about the infections or the superimposed infections or, you know, the dehydration. Those obviously we have to take care of as well. But the idea to treat this particular patient acutely in an immediate acute setting is to lower the autoantibody titer. And what we will do that is with systemic steroids. And it's going to be a little long term. So what we'll do is we'll give them oral steroids, you know, 1 milligram per kilogram of body weight per day, you know, for about 6 to 9 months. All right. And the reason we have to weighing these guys down and bring these guys off of the steroid is because steroids are associated with a high morbidity, all kinds of other problems, infections and stuff. So we need to get them off of that. When we are getting them off of the steroids, we give them immunomodulators. So what we will do is we'll add immunomodulators to the equation as we're weaning these guys, after we're tapering the guys or the patients off of the steroids. And that happens to be one of those is azathioprine, which is a 6-MP or 6-mercaptopurine antimetabolite, or mycophenolate. And mycophenolate basically works by inhibiting B and T cells. So we're bringing down our immune system. We're shutting down the immune system a little bit so it stops auto-activating and creating antibodies against the epidermis. Now, if by any chance these were unresponsive, the patient was unresponsive, this is called a refractory patient. They're unresponsive. We give them rituximab or rituximab, which is an anti-CD20 antibody, so it's going to work against the B cells. We give them about 370 milligrams per square meter of the body, and we give them IV Q weekly times 4 weeks. So there's going to be 4 doses involved at 375 milligrams per square meter of the body. We also, studies have shown that together with intravenous immunoglobulin, it works much better. So sometimes we combine these to get better efficacy. And that's pretty much it. That sums up our discussion on Pemphigus vulgaris. Please, you can follow us on Twitter. You can follow us on Facebook. Please like, share, subscribe. We do appreciate all the comments and the feedbacks from all you guys. So just keep it up, and we'll keep doing what we're doing. Thank you.